Our next presenter is Dr. Stephen Johnston of the Royal Marsden Hospital, who will be presenting abemaciclib plus endocrine therapy for hormone receptor positive, HER2 negative, node positive, high risk early breast cancer, results from the pre-planned monarchy overall survival interim analysis, including 4-year efficacy outcomes.
Thank you very much, and thank you to the organising committee on behalf of my fellow monarchy investigators for selecting this abstract and the opportunity to present the results of a pre-planned overall survival interim analysis, including 4-year efficacy outcomes. These are my disclosures. Adjuvant abemaciclib combined with endocrine therapy has previously demonstrated significant improvement in both invasive disease-free survival and distant relapse-free survival in high-risk, node-positive, hormone-positive, HER2-negative breast cancer. When statistical significance was first met, follow-up was limited, a median of 15 months. Although a subsequent analysis has confirmed abemaciclib treatment benefit persisting beyond the 2-year treatment period. Data presented today are from a pre-planned overall survival interim analysis defined to occur 2 years following the primary outcome. All patients are now off abemaciclib. Median follow-up is 42 months, and we will present a landmark 4-year analysis. This slide shows the accumulation of data over time at the pre-specified analyses of the trial. The current analysis, 2 years after the primary outcome, was undertaken with the data cut in July of this year. Median follow-up is now 42 months, and there are 835 IDFS events now. The design of the study is shown here. The trial recruited high-risk, node-positive luminal breast cancer patients, and it's important to note that 95% of the patients in the trial received either neoadjuvant or adjuvant chemotherapy, indicating their high level of risk. The intent to treat population consisted of 2 cohorts. In blue, cohort 1 had high-risk clinical pathological features, namely 4 or more nodes, or if 1 to 3 nodes, at least one other factor, either grade 3 disease or large tumor size. This comprised 91% of patients in the trial. A second, smaller exploratory cohort was added later, looking at those with intermediate risk factors, 1 to 3 nodes, grade 1 or 2 disease, T1 or T2 tumors, where the only risk factor was a high cell proliferation by a central cutoff of 20% for Ki67. After standard of care therapy, patients were randomized to endocrine therapy with or without abemaciclib for 2 years, the treatment period, to be followed thereafter by adjuvant endocrine therapy for between 3 to 8 years. Primary objective is invasive disease-free survival. Secondary objectives are shown here. It's important to note out that by protocol, all patients were staged at diagnosis to exclude metastatic disease. Here we see the updated efficacy results for the primary outcome of invasive disease-free survival in the intent to treat population. You can see that with further follow-up, the Kaplan-Meier curves continue to separate beyond completion of the 2-year treatment period, suggesting a potential carryover effect. The hazard ratio of 0.664 represents a 33.6% reduction in risk in developing an IDFS event. And at 4 years, the absolute difference in IDFS rates is 6.4% compared to the 2- and 3-year differences of 2.8 and 4.8% respectively. The forest plots show consistent IDFS benefit in all the pre-specified subgroups with no statistical interaction. And now, with more events in the study, we have an even more precise estimate of the individual treatment effect in each of the pre-specified subgroups. Now, distant relapse-free survival is an important secondary endpoint in the trial, which excludes local recurrence and involves death for any cause or metastatic events. Again, you can see that the Kaplan-Meier curves separate and continue to do so after the treatment period, with a 34.1% reduction in risk of developing a distant event or death, and an absolute difference of 5.9% at 4 years. Again, treatment effects were consistent across all pre-specified subgroups. Now, in an exploratory analysis, piecewise hazard ratios within each year were estimated for both IDFS and DRFS. What you can see here is the magnitude of abemaciclib benefit increases year on year beyond completion of the study treatment period, again suggesting a potential carryover effect. Now, at this point, overall survival data in the trial remain immature in the intent to treat population. However, we can see a numerical difference with 157 deaths in the abemaciclib arm versus 173 in the endocrine therapy alone arm, with a point estimate on hazard ratio of 0.929. Now, this slide shows the status of patients who developed a distant relapse-free survival event, namely death of any cause or a metastatic event. In the light blue boxes in the histogram, you can see the patients that have died due to breast cancer, 118 in the abemaciclib group versus 139 in the endocrine therapy alone group. In the green boxes of the histogram, you can see those patients who've sadly developed metastatic disease but are still alive receiving treatment at the current time. And what you can observe is that there are half as many of those in the abemaciclib group compared to the endocrine therapy alone group. Now let's briefly look at efficacy in some predefined subpopulations in the trial. What you can see here are the efficacy in the two cohorts within the trial. Now, cohort 1, which was 91% of the trial, shows very similar hazard ratios for IDFS, DRFS, and overall survival to the main intent to treat population. Cohort 2, which was the smaller group of 517 patients recruited with intermediate risk factors but a high Ki67, the events are too few, only 44 IDFS events, 33 DRFS events, so the data are far too immature to draw any conclusions at this time point. Now, Ki67 as a marker of cell proliferation was analyzed in a pre-treatment biopsy centrally in patients in cohort 1. And what we can see in this slide is that Ki67 is clearly prognostic in this trial. Concentrate on the blue curves, which are those patients treated with endocrine therapy alone. And you can see in the solid line, those with a high Ki67 had a much worse prognosis than those with a low Ki67, with 25%, a quarter of the patients, having relapsed by 4 years compared to 17% with a low Ki67. If you now look at the red lines, you can see the additional benefit of abemaciclib in the high Ki67, the solid lines, and the low Ki67, the dotted lines. In the table, you can see very similar hazard ratios for IDFS and DRFS in both the high Ki67 and the low Ki67, suggesting that abemaciclib's treatment effect is seen regardless of Ki67 score. Now, the safety data in the trial were consistent with previous analyses and no new safety signals were seen. The majority of adverse events occur early in patients on the study and are managed by appropriate dose holds and dose reductions, which were common in the study to allow patients to stay on study for the 2-year treatment period. Discontinuations were 18% and less than 9% if patients had had a dose reduction. So the safety profile of abemaciclib is considered manageable for these high-risk patients. So to conclude, with additional follow-up, the benefit of adjuvant abemaciclib has deepened in magnitude with an increase in absolute IDFS and DRFS benefit at 4 years compared to the 2- and 3-year estimates. The benefit appears to be consistent across all pre-specified subgroups, and while Ki67 is an important prognostic factor, abemaciclib benefit appears to be similar regardless of the Ki67 score. At this time point, overall survival data are immature at this interim analysis. Fewer deaths were observed in the abemaciclib group compared to endocrine therapy alone, and continued follow-up of overall survival is important. So these data support the addition of adjuvant abemaciclib to endocrine therapy for these high-risk node-positive patients. We're grateful to the 5,500 patients and their families from over 600 centres in 38 countries for their involvement in this trial and the support staff at each centre. And today we're pleased to announce that the full manuscript of this data and all the analysis in this interim analysis are published this afternoon in Lancet Oncology, and you can download the paper at the link shown here. Thank you.
Thank you very much, Dr. Johnston, for that very exciting presentation. I'll open up the floor to questions, starting with microphone 3.
Steve, how many patients on the trial actually had a dose reduction?
Dose reductions occurred in 43% of patients on the trial.
And how many went off the trial because of side effects?
So the discontinuations in total were 18%.
So despite that, the outcome was favorable in favor of abemaciclib. Isn't that an argument, and also relative to Polly's talk just a minute ago, about the drug companies starting to assess not dose-limiting toxicity as the dose that they follow up with, but doses that inhibit the target? And rather than just giving, like we studied chemotherapy for years, using the dose that gives us all the dose-limiting toxicity dose.
In clinical practice with abemaciclib, I'm very clear with my patients that we find the dose that's right for the patient. These drugs were developed in a flat dose session, in a flat dose way, but we have to find the dose that patients will tolerate, but also that are effective. And ultimately, with these targeted therapies, as we've seen in a number of trials, it's the ability to stay on drug for a defined period of time, the at-risk period over 2 years, that is likely to produce the therapeutic benefit. So finding the dose that's right is all important.
Yeah, I agree with that for sure. But you think the drug companies, though, would study it in that way at the beginning so we'd know the right dose that patients can actually tolerate?
I agree, Ken.
Microphone 4.
Hi. Thank you very much, Steve. Vogel, New York. I have a theoretical question for you. The drug works. More than 80% of the people can tolerate it. Have you given thought to giving it longer? The people still on it, how well, do they do better than the people who stopped earlier? It seems to me if a drug works and it's an adjuvant study, perhaps 4 years is better than 2, and you can study that in 80% of the patients.
Duration's an important question, and when we designed the study, we looked at what we thought the optimal risk period is and what we thought the likely durability of tolerance for the drug would be. As you know, in the other adjuvant CDK4/6 inhibitor studies, one did 1 year, and there's an ongoing study that's looking at 3 years. But regardless of that, I think it is the ability to stay on drug for a defined period that's important. Whether the risk disappears at 2 years, if you're eradicating microscopic metastatic disease, I don't know. And that's where following the separation of the curves is all important. Because if you've delivered your treatment effect within that concise period of time, 2 years may be sufficient.
Microphone 2.
Olopade, Chicago. 2 questions. Did you look at grade, and could grade substitute for Ki-67? And then second question, how many non-white patients participated in the study, specifically black patients?
As far as the second question is concerned, there were a number of different races. The precise figures are in the manuscript that's just been published. As far as the first question about grade is concerned, these were pre-specified subgroups, and a benefit was seen regardless of grade. It was weighted to more grade 3 patients because that was an eligibility criteria within cohort 1. But in cohort 2, which was a smaller group, grade 1 and 2 tumors were allowed if they had high Ki-67. But that's very unlikely in a grade 1 tumor.
And final question from microphone 1.
Hello, thank you for your presentation. My name is Karine, and I have a question about patients who achieved complete pathologic response rate after neoadjuvant chemotherapy, and say they had all the high-risk features for positive lymph nodes, tumor more than 5 centimeters, but yet magically they achieved PCR. Did they derive the same benefit from abemaciclib as patients who did not have PCR? Thank you.
So complete pathological responses with neoadjuvant chemotherapy in luminal breast cancer are rare events. Now, there was a previous publication from Martin et al. In JAMA Oncology, which has gone into all the neoadjuvant data, and you can look at the patients in that group. But there were so few patients that achieved PCR, we couldn't differentiate statistically whether they were deriving the same benefit or not.
Thank you again, Dr. Johnston.
Thank you.